So yeah, Dr. Baenziger, if you could just introduce yourself, talk a little bit about how you got involved with global health or what your thoughts are on it broadly, and then we can get into more specifics as we go along. We are recording this, so I'll post it and others might be able to see it later.
Awesome. So, and we've got two fourth years, Savannah, you're going into third year. And Joe, what about you?
Also graduating fourth year, staying at IU for Med-Peds.
Excellent. Great choices, guys. And for all those who might watch this recording later, welcome. So thanks for having me. I also went to IU for medical school and then stayed for Med-Peds residency because it was a great program and it is a great program. So just a little bit about Med-Peds, like why I found it or how it fits for me. I didn't know what it was at all until I shadowed an internist after first year of medical school. At that time, there was like a hospital medicine program where you could shadow 1 week in each thing after the summer first year. And I will never forget watching him talk about the pathophysiology of cirrhosis and how portal venous hypertension led to this lady being anosarchic and having her lower extremity edema and the varices and connecting it back to the anatomy that we had just learned. And I was like, oh, you are totally my people. And then of course I love peds and got to see the same thing when I was doing GI on peds, seeing biliary cirrhotic kids, presenting just like our adult patients and the same pathophysiology, same great patient care. So realized I love Med-Peds, and going on the interview trail, it was just really clear, like those were my people. Every interview day was fun. I got to hang out with people that really loved medicine, also really loved the art of medicine, and were just generally really great to be around. So hi everybody. So went through residency. In residency, I got to be a part of the first global health residency track at IU. So I was the inaugural class run by Dr. Jill Helfenstein at the time. And it was great. And then I became faculty. So ever since, I'll talk a little bit more about what happened after residency, but kind of why global health for me too. I grew up in a very globally minded family, although my parents never, my mom in particular, never even had a passport. But that didn't stop us from making bandages for people in Africa. Yeah, I say Africa because when I was growing up, I thought it was just one country. Um, so we would do that. We would have like fundraisers for different people across the globe. We went to a church that was like a missionary church, so our church was very like aware of people around the world and the needs that they had, and so it was just a very like broad experience as far as what we cared about. But I had no actually experience doing anything until college. I went to India for a month in college and got to work in a hospital there, and it was amazing. Looking back, I kind of can't believe that my mom let me go. Like, I just showed up this single white girl and didn't know anybody, really didn't know how I was getting around anywhere, and just tried to find my way to this hospital. But it all worked out, and it was a great experience. And the people working there were just very, I think, aware of all the social determinants of health that were affecting their patients. I'll never forget them saying, alcoholism is alcoholism in any country, and seeing a patient in front of me that was just really struggling with their addiction, and thinking about the patients and the people I knew back home with the same thing. So, and then in medical school, through different life events, I actually never went to Kenya, but I went to Honduras in medical school for a month. Mostly really wanted to learn Spanish and wanted to see that system. So got to touch down with the Enlace program there. I don't know if anybody's gone with them, but it was a phenomenal experience. It was also the most terrified I've ever been in my entire life, getting dropped off at the door of this house, this sweet host family, and I barely knew how to say hi to them in Spanish. And they were so kind and taught me a lot. And by the time I left, I could converse and watch movies with them in Spanish. So I felt like it was a win. But not to mention got to see the medical side of the world. But so fast forward to when I was a faculty. So I knew going into Med-Peds and all along I've always loved education. I knew I loved teaching in various contexts. That's partly why I love Med-Peds, because you get to teach patients. You know, the well child visits are mostly education, and then a lot of critical thinking about things that the kid may or may not have. So I love that. I also really knew that I still cared about all these populations that I had got to see. So, you know, India, Honduras. And then, you know, living in Indianapolis, my husband and I have always lived fairly intentionally in areas that were not the highest socioeconomic areas. We had one car for a lot of medical school, so we intentionally lived on a bus line and took the bus with people of lots of different stripes living here in Indy, all during med school. So it just reinforced the fact that like there are people that have healthcare disparities for me in any place where you choose to be. So so I knew that I wanted to focus on, or wanted to do something to improve the care of patients, no matter where their situation was. You know, I always think about like, if I happen to be a person that was born in X country instead of where I was born, which is in, you know, semi-rural Indiana, what would my life be like? And what options would my mother have had if I got sick? And what would have happened if I got the same, you know, infections? Those disparities and like those options really still drive me. So, and now that I'm a mom, thinking about if we just happen to be Kenyan instead of Hoosiers, when my kids get sick, you know, I get to go to the ER if they're sick here, but those moms don't have that choice. So it's tempting to go and do the care. I really love patient care. But I also knew I had a husband that was in medicine. He is in medicine. He's a palliative care at St. Vincent. So he needed to finish training and do his job. And I also knew I had an aging mom, and my husband has an aging mom. So right now our life is centered here in the US. So and it needs to be for right now. So there might be at some point in my life where I'm going to do primary hands-on care in a different country, but for right now, I knew I needed to be here. So thankfully a job opened here at the Center for Global Health, which is all global health education. So it was really a perfect fit. They advertised for it, and I jumped on it at the moment's notice. So the job that I do now is leading all sorts of global health efforts across the education realm. I mean, you can really summarize all of them with the idea of how do you increase the workforce in the world that is culturally humble, has the skills they need to take care of a diverse population, is aware of different contexts in the world, and is prepared to address healthcare disparities. So we do that in a lot of ways. In many ways, we're very limited because of just time. There's only a certain amount of time that I get to do this job. So I can dream really big, but the things I get to do in some ways are great, in some ways feel very limited just because of that. But so I was looking at my schedule. Maybe I'll pull it today. I made this schedule this morning for my own purposes of all the different things I have to do throughout the year. But so I lead our global health residency track. So we have a interdisciplinary track, that same one I joined back when I was in residency, and do different didactics and sessions and etc. All focus on residents, multiple different residents. We can talk more about that if you guys want. But I lead our elective to Kenya for both residents and students all across IU. I lead another fourth-year elective called Healthcare in Developing Countries. So if students want to go to India or like I did, or other places they can go, they can it's a create your own global health experience. There's lots of stipulations, but part of that exchange or part of that elective that we send students and residents to Kenya is that we also receive them here. That's one of our core values here at the Center for Global Health, that anything we do needs to have a bilateral component, that we're not just dropping students off in a different country, but we're really building collaboration and connection over time. So we have Kenyan students here. Not only do we have Kenyan students here, but we have them across the AMPATH consortium site. So there's all these schools in the US that collaborate and work together. And I help to lead all of the student exchange. So there's, for example, this year there's 14 Kenyan students that are going to like Duke, Brown, Toronto, UCSF, a few other places. So we're helping coordinate all those, making sure those students can do those electives. So we do a first year elective, a first year scholarship that Michaela did last summer called the Slamenda Scholars, where first year students in between their first and second year receive a stipend to go and spend a summer in Kenya doing global health related things. And there's a few other various things, but that's the meat of it. So yeah.
Awesome. Thank you so much. I think that something that stands out about IU is how collaborative we are with the partners. I don't think that's something that all medical schools do well. So thank you for making that happen. I did just want to ask real quick, is Dan's iPhone Dr. Guiles by chance? If not, no worries. If it's a student, but I just wanted to make sure we were giving you a chance to speak.
Yeah, this Dr. Guiles. Sorry I joined a little bit late. We just finished up morning session of clinic. Is this just introductions or?
Yeah, thanks for being here. We were just kind of introducing maybe why Med-Peds, why global health, and maybe like how you got involved with global health, that type of thing. So basically an intro, yeah.
Sure. Yeah, I'll try to be brief here, but yeah, I did my medical school at IU. I was actually in the same med school class and residency classes as Dr. Baenziger, which is kind of fun. But I grew up overseas. I was born in the U.S. but lived from age 3 to age 15 in Buenos Aires, Argentina, and so was sort of exposed to different cultures from a young age. Decided throughout my high school career to end up pursuing medicine, and really with the intention of doing global health. I think a lot of my experiences as a child sort of played into that decision. So I ended up at IU for med school and stayed for residency, and was really drawn to Med-Peds primarily just because of the great Med-Peds culture that IU has, and seemed like the Med-Peds faculty were doing a lot of the things that I was interested in doing, and it seemed like just a great fit, not only personality wise, but also, I was interested in a wide variety of different disease processes and populations, and wanted to do more peds than what like a family medicine residency would offer, and so ended up matching at IU for Med-Peds residency. While I was here at IU doing training, I did an elective with the AMPATH program in Kenya, and spent 2 months there. It's actually where I met my wife. My wife was a neonatology fellow at the time who was doing research, and we happened to be at the same place at the same time, which was kind of fun. And then ended up working after training, working for a local underserved clinic called HealthNet, Southeast Health Center, primarily with Spanish-speaking patients, for a couple years. After that, I decided I wanted to do more overseas type work, and so I ended up actually going back to school full-time at Tulane University in New Orleans, getting a master's in public health, tropical medicine. That sort of led to opportunities to live in Uganda, and I worked for a program there that in some ways was similar to what AMPATH is doing in Kenya, focusing a lot on education, on healthcare delivery, but also on research. And so was able to be involved in some really cool public health uh, programs there with children under the age of 5. Uh, that unfortunately only lasted about a year and a half because the funding for that position ended up going away. And so I ended up relocating back to the US, worked at Vanderbilt for a while doing primary care. Med-Peds also was in charge of the student elective for global health over at Vanderbilt University. Likely would have been there a lot longer, except the position opened up in Kenya at the time. So I ended up actually moving to Kenya with AMPATH. I was there up until about March of last year, where I was the pediatric team leader, essentially helping with the learners that come from IU and rotate through pediatrics. Then I've been back in the US about a year. I work at Eskenazi Grassy Creek currently, and even though I'm not living in Kenya or Uganda, I still get to do a lot of global health in my day-to-day practice. We see a lot of immigrant families here at Grassy Creek, primarily from Latin America as well as from Haiti. So a lot of patients who don't speak English, and we have a whole host of questions about how to engage with the healthcare system here. Maybe have a lot of medical issues that have gone undiagnosed or untreated. And so I still feel like I get to do a lot of the global health stuff that here locally currently. So yeah, I don't know if there's anything else.
Oh, that's great.
That?
Morgan Johnson recommended that I reach out to you, and now I see why. You've got great experience in global health. So thanks for all that. I think maybe another question is how has Med-Peds like uniquely helped you in the field of global health? I know across the interview trail, a lot of programs said like our program trains you well for global health. How do you feel like in your career Med-Peds has helped you as a global health physician?
Yeah, that's a great question. I think there's a lot I could say about that. I think primarily with pediatrics, which is what I've done most recently overseas, I feel like a lot of the conditions that you see in pediatric patients abroad really mirror more of the conditions we normally see in adults. And so, for example, a lot of the peds patients that I was seeing in Kenya up until a year ago were rheumatic heart disease complications. And so a lot of those conditions were very similar to like heart failure in adults. And so I felt like having that adult training in heart failure was really helpful to be able to then feel more comfortable in helping these kids who, we don't really see much rheumatic heart disease here in the United States. And so I think it's really helpful for pediatrics, where I feel like here in the US, a lot of our pediatrics tends to be prevention and well child visits, and those are great, and there's a lot of important aspects of that. But I feel like a lot of what's seen, at least in Kenya and in Uganda where I worked, are sort of complications of diseases that we may not get much exposure to here in the US, but that have similar counterparts in the adult world. So I feel like that's where Med-Peds really has been really helpful. I currently have a friend who works he's a Med-Peds trained guy who works in a mission hospital in southern Kenya. And he really has been able to move the pediatric care for that part of Kenya for quite a bit. And a lot of that is due to his Med-Peds training. So he's comfortable taking care of real sick kids in the ICU. He's comfortable in the NICU. He's comfortable seeing kids in clinic. I mean, and similar to my experience, he feels like just the breadth of exposure, but particularly the exposure to sicker patients in the adult and the pediatric world has really been helpful for him to be able to succeed and to be able to help his patient population there in southern Kenya.
That makes sense. Thanks. Dr. Baenziger, do you have anything to add?
I think, Dan and I have talked about it a lot. It's just Med-Peds, you're pluripotent. Like if you are in a global health context and you have geriatric patients that day, you can take care of them. If your project ends up being more peds or your population, then you can take care of them. Like you are as versatile as it comes, other than family medicine. But I would argue perhaps a little bit more prepared to take care of the sick patients you're going to see in a lot of global health contexts. So, and that's, I mean, that can be true, I think, in lots of situations. For example, one of our global health researchers here at the Center for Global Health is an internal medicine doctor, and she's ended up doing most of her later stage career stuff on maternal mortality in rural Indiana. So, I think people that care about these things will find their niche, but at Med-Peds, you're just really well trained to do that. So.
Sure, that makes sense. If anyone on the or on the Zoom has questions, feel free to shout them out or throw them in the chat. But I'll ask another. Is there anything any work you've done abroad or something you've learned while doing global health that has changed the way you practice here in the States now that you are both back here for the time being, at least practicing?
Dr. Guiles, I'll let you talk in a minute, but I think cost awareness is a huge thing. I mean, when I go on Eskenazi wards now, the first thing I do is cancel all of the daily labs that people order, and I make my team think about which ones they actually want to get, and if anything is actually going to change their management tomorrow. I'm sure it's really obnoxious, but every day I'm like, why? Thinking, why do we don't need all these things that are just ordered routinely or rotely. There's a lot we do in the States that we only do because we have a very low tolerance for uncertainty. So trying to find those areas where you can really save patients money, that are at least being awareness. But I think even maybe more importantly than that is just a huge awareness of social determinants of health. Like when you go to a global health context, whether it happens to be on the east side of Indy or India, those social determinants of health are in your face. Like your patient can't afford their antibiotics because they don't have money, or in order to fund the antibiotics, they need to go home and kill a goat and sell a goat. On the east side, my patients can't get to physical therapy because the only place to do physical therapy is downtown or on the west side. And that cab ride is going to be too much money, and there's no way they could afford an Uber. So like daily, constantly thinking about like transportation, food insecurity, housing insecurity. Those things are, I think, now way more ingrained in my head because I've seen them what's like in these multiple contexts. So.
Yeah, I agree with everything Jenny said. I think, yeah, the big one for me is cost. Like Jenny already said, I think we're so far removed from the cost question here in the U.S. I mean, I feel like we order a bunch of tests or, imaging studies, and then the patient gets them, and then there's something that happens in the insurance world or whatever that somehow gets to the patient eventually. And it's really hard to really think about that. Whereas when I was working in Uganda or in Kenya, that was one of the main things we talked about on rounds or in clinic was, what tests should we order? What tests are actually available, and then what tests can the patient actually afford? And oftentimes, our list would get significantly smaller as we would go through that process. And so I feel like here it's easy to not think about that and just order a bunch of tests that may or may not be needed, but we need to remember that eventually it always comes back to the patient somehow, whether it's through higher insurance premiums eventually or bills that they'll get later in the mail, and really what's a good use of medical resources here. And so I think that's a huge one that I've taken. The other one that I'll mention is I've learned to rely more on my physical exams. I feel like oftentimes in situations where you don't have much resources, you really learn the value of the exam, whereas here we tend to rely more primarily on x-rays or lab tests to make the diagnoses for us. And so as an example, I'll talk about how in Uganda, I had a colleague who diagnosed a pneumonia based on exam. And then we got an x-ray, and the x-ray didn't show any infiltrates, but he was still very confident in his diagnosis and said, well, this patient's very dehydrated. Likely if we hydrated them more, he would have an infiltrate on a repeat image. So still was very confident in his exam, and he ended up being correct. So I think that just was really inspiring to me to not rely so much on imaging, and to really try to hone my physical exam skills and become a better physician in that way. And so I think those are the two big ones that I've taken with me from my time overseas.
Thank you. Yeah, that's a really cool example, because I feel like here we just jump to imaging immediately and don't even consider other options. So that's cool. Does anyone else have other questions? I don't want to steal the whole show if other people have thoughts.
I had a question. I think I've been frustrated kind of throughout the clinical years whenever I have a patient who's not English speaking. And I was wondering if you guys have any tips on working with patients that might have a language barrier, how to better connect with them and better educate. Because I feel like as awesome as the resources are, or translation, I feel like there's always kind of a point where I'm not fully connecting as much as I wish I could, and always feel frustrated after the fact. And I don't know if you guys have any tips on that.
Yeah, I can speak to that. So I think first of all, I'll be the first to admit that it's really hard. I mean, I'm fortunate enough that I do speak Spanish, and so I'm able to communicate with my Spanish speaking patients, but I see a lot of Haitian Creole speaking immigrants here as well at Grassy Creek. And so definitely I think you're very dependent on the skill and the quality of the interpreter that you're using. And there are certain situations that can be really challenging, particularly when you're talking about more complicated medical diagnoses or procedures, and it's hard to know if things are being communicated the appropriate way. But I think what's made a big difference for me has been to, try to communicate as much as I can non-verbally. And what I mean by that is, I feel like oftentimes as physicians, we're trying to get through maybe our list of items we're trying to educate the patient on, or trying to explain things. And it can be very easy, whether you're dealing with a English speaking patient or a non-English speaking patient, to just quickly go through that and not necessarily communicate empathy or caring through your nonverbal cues. And so I feel like trying to sit down, make eye contact with the patient as opposed to the interpreter, responding nonverbally to some of their cues that they have. I feel like it just allows you to make that connection with the patient that is otherwise really challenging because you don't speak their language. So I feel like that's been very helpful, but also realizing that the interpreters often aren't medically trained, and so trying to explain things in as patient-friendly language as possible, which is something we should be doing anyway, but it's especially important when we're using an interpreter. And asking the interpreter to clarify things as well. I think sometimes I can tell like a patient didn't quite understand, or maybe things didn't communicate quite the way that you had thought they would. And so asking the interpreter, well, what did you say? Or how did you explain that? Could you tell me in English so that I could hear, and maybe provide maybe a different way of explaining, or a different way of doing that. And something that I don't do a lot, but that I've heard other people do, is they'll keep the interpreter after the visit is over, and they'll ask the interpreter for feedback, or maybe ask the interpreter if it went well, or if there were any cultural barriers that they identified. And I think that is something that I probably should do more of, that I don't often do, but I've heard that can be really illuminating, particularly when dealing with patients who are from a very different cultural background.
I would just add, like, force yourself to do like 2 minutes of small talk. Like most cultures in the world other than ours rely a lot on that interpersonal connection. And so you will get much better medical information in your subsequent 20 minutes if you put a little effort up front at doing, even though it's in some ways painful to spend the time, especially with an interpreter, to like talk about the weather for a second. And the interpreters can get really thrown off because they're like, wait, what? This is just fluff. You don't really need me to interpret this, right? But if you're like, no, really, I want you to ask about their red shoes and where they got them, I think it goes a long way. Also, I would say I probably shouldn't say this on a recording, but feel free to just hang up the interpreter and get a new one if they're not good. Like sometimes some interpreters are just not going to connect with that patient or not going to like, and it's okay to just, if you have the luxury of time, it's okay to just hang up and try again. I've definitely done that and had good success sometimes.
Thank you. Yeah, super helpful and useful tips.
And if I could just add one more, I think take the time to learn basic medical terminology or exam terminology, or even like basic medical commands in the language. It's so helpful to just be able to tell a patient in their own language, could you sit up, or could you lie down, or take a deep breath. It sort of makes the visit that much more efficient, and it also shows them that you're invested in them and trying to learn their language. Maybe also learning greetings in their language, so that you're saying hello and how are you, can also help with connections. And so I think just taking the time to learn maybe some basic medical phrases, some basic greetings, basic commands can be really helpful as well.
Thank you. Any other questions from the group?
I have a question. So if you know you want to pursue a career in global health, are there any things that you would recommend doing or experiences worth having in medical school or even in residency that you recommend you should absolutely do? Or I guess kind of alternatively, what does a global health track in residency, what can it offer you in your future career?
I think it can offer as little as networking. At minimum, you should find friends and like-minded peers with a global health track. So if you're looking for a residency that has one, at minimum, it should connect you to other people that have similar interests and care about the same things, because they'll help propel you and help you ask good questions, and you'll just enjoy being around them because they care about what you care about. Ideally, a global health track would really advance wherever you are and make you better at it. So if you want to be an excellent global health clinician, then it would give you the skills to do that, like procedural skills and disease knowledge and extra training in cultural humility and cross-cultural situations. If you wanted to be a global health researcher, it would give you actually great epidemiology information and maybe even statistics training, international IRB approval processes, like global health research ethics. You could kind of think about more what you would like to do, research or clinical care or education. And I think some tracks will be good at all of those, some will be good at none of them, but it might help you think about what you want to do more. As far as I say over and over, to be a good global health physician, you need to be a good physician first. So no matter what, focus on your residency, because if you're at a good place and you're training to be a good doctor, that's your first goal. Because if you're a bad doctor, you can't be a good global health doctor. And so I do say that partly to not to give you a pass, but just to say residency is busy. Medical school is busy, and if you don't have a lot of time to do extra things, it's okay. You're doing the thing you need to do to be a good doctor. If you have time and effort, I you know, in medical school, you may not have lots of like big chunks of time, but learning a language, you may not even know if you're going to use that language, but learning any language can help open up doors. Doing things like Fogarty scholarships, where you actually spend a year in another place in between years, like particularly your third and fourth year of medical school is often an option. If you know you want to, like, let's say you know you care about East Africa, actually spend time in a different place. So go to Central America during undergrad or like medical school or residency, or if vice versa, because I think there's a lot to be said for seeing different contexts, and just getting a sense of how multiple places around the world work. There's also a lot to be said for digging in and diving into one place a lot. So your context may be different, but one of Dan and I's other good friends was like amazing at getting him extra skills in residency by just pushing himself. Like he would, he knew he was going to go and work in an international context full term. So he would spend like his afternoons in continuity clinic. Like he would make sure he did all the blood draws for the patients because he wanted to get really good at it. He went and spent time with the echo techs at Riley because he wanted to learn how to do an echo because he knew he was probably going to be one of the only docs doing it in that context. And people here are really willing to let you learn most of the time. So those sort of like peri-physician skills that are still easy to access while you're here, think about if you're going to need those with the kind of career you want, and with the situation you think you might end up in. So.
I won't add a lot to that. I think Jenny is, I think the expert in that. But I will say that it can feel a little daunting at times. I think it's not a career in global health is not as well defined as maybe a career in, say, cardiovascular surgery or cardiology, or all of these other careers that maybe your peers are considering. It's not like you go through residency, fellowship, and then all of a sudden, yeah, you're qualified and you're ready and you're doing it. I feel like it's a lot more nebulous and requires a lot more maybe investigating. There are a lot more options, and so I think it can feel a little bit daunting at times to really sort that out. And some of it is just sort of figuring out what where your interests lie, and maybe trying to connect with people who are doing similar things to what you're interested in, and just picking their brains and saying, hey, how did you get here? What training was helpful? What was useful for you as you sort of forged your own path in global health to do X, Y, and Z, and how might somebody like me take those steps? And so I think really, I think the networking piece and sort of figuring out what other people are doing and where you fit in that, I think is probably just as important, if not more important, than whether or not you do a trip during your residency or your medical school. I think sort of figuring out what others have done and how they've gotten there, I think can be helpful, because it can be pretty vague, pretty tricky otherwise.
I put this quote in because it's like I come back to it a lot in my life. Like, I don't know if it was really Aristotle who said it, that's what the internet says, but like, where the needs of the world and your talents cross, there lies your vocation. Like, I think that's helped me a lot to be like, all right, what am I uniquely good at? Where do I see the needs of the world matching it? And that's the place where I'm going to go forward. And a lot of global health, when you listen to the careers of global health doctors, a lot of it is like, well, this is what happened next. Like, I didn't plan this. I didn't really know that this was going to be available. I was kind of looking for this arena. I knew I really valued this. And then this came up. A lot of it is sort of like helter skelter. But in retrospect, it looks like this beautifully laid out global health career. So I totally agree with Dan. It may not feel organized up front, which is a little bit antithetical to who we are as Med-Peds doctors. But.
Thank you. Those are really good pieces of advice.
I agree. Yeah, that was great. Anyone else? Other great questions so far. Does anyone have any others? I was going to ask, you kind of talked about this a little bit, but when it comes to finding work or a job, how have you communicated that you're interested in global health? How have employers offered opportunities, specifically at IU, or if you've worked anywhere else? Of like, how do you go about finding a global health career or a job that will allow you to travel for part of the year? If you could kind of talk about that.
So I think a lot of that depends on what you end up doing. I think there are certain types of jobs in Med-Peds that allow for more flexibility. And so, for example, like if you're a hospitalist and you work 2 weeks and you're 2 weeks off, that makes it very conducive to taking trips. I think what some people have done is they sort of combine some blocks together of hospitalists, and so they work maybe 3 or 4 weeks in a row, but then they get a month off to sort of travel and do things. And so I think even if your job that you end up getting doesn't necessarily have like a global health focus or a global health stuff built into it, if you do have some flexibility there with the schedule, you can still do a lot of trips or those sorts of things. I think that in the outpatient world, which is where I'm at currently, it's a little bit more challenging just because most practices don't really look highly upon you being gone for large chunks of the year. Could you negotiate that potentially? But I think people are less enthused about that. One of the nice things about Eskenazi, where I currently work, is they actually have a policy where they allow their physicians to use their CME funds and their CME time for global health trips. And that's, I've worked a lot of places. This is the first place I've worked at where that's been actually written into the policies of the organization. And so that's really nice. And so in February, I took 2 weeks where one of the weeks technically was vacation and the other week counted as CME time. And I went to Kenya for 2 weeks. And there were no questions asked about that. It was very easy to get that approved just because of our policy. And so maybe looking into those sorts of policies. I think where it tends to be a little more clear cut is if you are actually involved in global health research or public health programming, where you actually have external funding to do work overseas. And so whether that's through NIH funded research or maybe you have a donor or a grant that's funding a certain project, usually that, then they're actually paying part of your salary through that. And so generally that comes with the expectation and the protected time to make those sorts of trips. And so I think it tends to be a little clear cut if you have some sort of project that you're working on. But if you're working a clinical job and you're needed to take time off, sometimes that can be a little tricky.
My only other piece of advice, whatever you do, advocate for it upfront. Like sometimes your only option for negotiating is when you're signing your contract. So if you're looking for jobs, I would not assume that you're going to just work there for a couple of years and then you're going to start taking a couple months off to go do something else. In my knowledge, that rarely works. It doesn't mean it can't work, but your best, just remember how you have a lot of leverage up front when they're trying to hire you. So ask for what you need and such. I am sad we couldn't hear from Dr. Ellis today. He's one of our Med-Peds hospitalists because he has had such an amazing global health Med-Peds career. And I say amazing because he's kind of lived like 9 lives. Like for his first decade, he worked all outpatient and did half of the year in Kenya, half of the year here. And then he did inpatient for a while, and then he worked full-time in Kenya for a couple of years, and now he's a full-time hospitalist. But he's just kind of changed jobs whenever he needed to, honestly. Usually within Indianapolis, usually within the same set of organizations, but he hasn't been afraid to just say, okay, this job isn't going to be the right for me because I want to go live in Kenya for 2 years. And then he's come back And the nice thing about Med-Peds, and this may not always be true, but there are lots of jobs, and because you're pluripotent, as I said, you have a lot of job freedom that other specialties don't have, which is really nice. So
Thank you.
I have a quick question. For a place like IU, I know that the funding isn't like upfront for traveling. Do you find that there is ample opportunities to apply for funding or fundraise, and does that continue on when you're doing a career? Like, do you typically get grants for it, or is that only if you're doing research? And then how would you fund it?
do you mean as a resident, applying for stuff as a resident, Joe, or what?
Yeah, like initially just for a resident, but then even like if you were going to travel after you're a resident, like do you try to get that built into like CME, like Dr. Guiles was saying, or do you do some other funding for it?
Dan, you can answer too, but I mean, really, when it comes down to global health funding, I don't know how to say it succinctly, but somebody has to pay for it, right? So it's either got to be you or somebody that's giving you a grant to do work overseas, or donors of some sort. So if you want to go like stop your clinical work here to go do clinical work there, there's usually not a good way to do that. There are ways to do it, but it's not. You're gonna be hard pressed to find somebody that will pay you to do that, unless you're working for more full time for an organization like MSF or like a non for profit. So doing like direct, like short term clinical care, you're probably going to end up paying for. If you have grants or projects or research that are going, that's what Dr. Oz was talking about, where you've actually applied to like the NIH or the Gates Foundation or some organization that's giving you money to do said project, and they will often pay for your travel and sometimes your time to do that. Dan, do you have more? I'm sure you have more insights to that than I do, but.
Yeah, I think yeah, definitely everything Jenny said, but I think, you know, as a physician who's working clinically and funded clinically, you essentially get paid for seeing patients. And so if you're seeing patients, you get paid. If you don't see patients, you don't get paid. And that's kind of an oversimplification, but I think that's a helpful way to think about it. And so I think like I said earlier, there are certain jobs that do offer a little more flexibility. Like if you're primarily hospital based, where you're doing big chunks of clinical time at once, and then you have built-in time off after that. You know, I think that sort of makes it a little bit easier because you do already have time where you're not working. But I think where it gets challenging is if you're primarily outpatient, where, you know, you get paid based on either the hours you work or the number of patients you see, the number of RVUs you make. And so if you are to, you know, like when I worked at Vanderbilt, I was RVU based. And so what that meant is based on how many patients I saw and how high I billed for the services I gave the patients, I got reimbursed a certain amount. And that's how I made money. So I could take a week and not see patients, but then I wasn't essentially generating any revenue for me, which meant I wouldn't get paid for that. And so I think that's primarily how it works if you're primarily a clinical physician. But if your time is split between clinical duties and say research or public health projects, to where you have some other external funding, either through a grant or through a donor or through the NIH, to where your projects are global health focused, that tends to be a little more clear cut because you actually have funding from one of these external sources to do the global health work. And most of the time that does involve some amount of money for travel and for being there on site to actually do the research, to check in with your investigators there, your collaborators there. And so that tends to be the way a lot of people end up funding their global health, is through these external funding sources.
I think that's one of the reasons, Joe, why a lot in global health especially if you want to do like clinical work overseas, live well within their means here in the States. Because as a doctor, you're gonna have plenty of money. If you wanted to travel, you could do that as long as you live well within your means here. So that's one thing I love about global health people in general. They're not gonna have, they, especially because they're going to other places and being confronted with the reality that most of the world lives on a lot less than we do. Some of my favorite global health people have lived in the same house that they've had since residency, and the same, car that they've driven since their first faculty job. So I think if you live within your means, you're going to have a lot of options to do it. So.
Great, thank you.
We are closing in on the hour, so I want to be mindful of you guys' time and really appreciate you all for being here. But maybe just some final thoughts or advice for Med-Peds, students interested in Med-Peds and global health, or any final thoughts from either.
Yeah, I think I would just encourage you guys to yeah, now that I think if am I correct in assuming that most of you are sort of third or fourth year students? Is that correct?
Yeah, I think so.
Okay. All right. To really take time during these last couple of years of medical school as you are sort of thinking about your careers and what you want to do and why you want to do what you want to do, to really just write that down. Write down your motivations. Why do you want to go into Med-Peds? Why do you want to do global health? Maybe what are some steps you're thinking about taking in order to, like Dr. Baenziger said, maybe some sacrifices you're thinking of making, or things you're planning on doing in order to get where you are, and just keep that written down in a place where you see it, whether it's on your mirror, on your fridge, just to remind yourself as you go into residency and have to go through a lot of long hours and difficult schedules and challenging patients, challenging experiences, just to remind yourself of why you're doing what you're doing, and keep you motivated to finish well and to really do well throughout your training. I think that was really helpful for me going through residency, to be like, well, this is really challenging and it's really hard. I'm not sleeping much. I'm up a lot. I don't have time to do some of the things I really enjoy or would like to do, but this is my goal. This is what I'm working towards, and it'll be worth it in the end.
I totally echo that. It may seem really sappy, but like finding friends that can support you and like call you back to your original mission. I mean, like Dan has absolutely been that in my life. Like, yeah, this residency is super hard, but remember why we're here, and remember why we're doing it, and remember what kind of patients we set out to serve, and remember why, that this is a really cool thing that we get to do. So med school can be super isolating. So in these last couple of years, especially, like, find your people that are going to call you back to whatever your true path is. It's worth investing in people, especially these last couple of years. So.
Thank you so much. This has been very inspiring, and excited to go on do a global health work. So thank you guys. Does anyone have any final questions or thoughts that they wanted to share before we wrap things up? Dr. Guiles, is it all right with you if I post this? We had some people not able to attend, so I recorded it.
Yeah, that's totally fine. And if feel free to email me, or if you have any other questions or want to meet up, I'm happy to take the time to do that. I'll put my email in the chat here. Looks like Dr. Baenziger put hers in as well. So.
Great, yeah, and I'll send a follow-up email to everyone too, and share your contact info. So thank you guys for taking the time out of your busy schedules in the middle of a Thursday. So really appreciate it.
Thank
No
you.
problem. Happy to do it. Thank you guys.
Thank you.
See you guys. Good to see everyone.